Thank you very much for coming to attend this presentation. It's a little bit late after 2 years since June 2011 when I became professor, so it's an opportunity to present some of my thoughts and the way that I think what is important in the specialty that I'm practicing, cardiac surgery, but also it's an opportunity for me to focus on some areas that have to do with things that everybody should demonstrate an interest, like recession, which is a characteristic of a global phenomenon that has taken place since 2008. So, when I decided to do this presentation, I thought to give a little bit of structure, because as everything that is complex is very difficult to express yourself in a language which is not your native language. So I have a lot of slides because I think that it's better to go through simple ideas that I think that are important to give the message across. So the way I structure the presentation is, first of all, I will explain why I have chosen this topic. Then I would like to talk about what are the effects of the recession. Then I would like to discuss some mistakes that have taken place during the recession and what we can learn from them. And I would like to go through the context of cardiac surgery and the way out for our specialty. And also, I would like to express some thoughts on research strategy and some other thoughts that I consider as important. So, if we think very well about what happened 2000 and a few years ago and how the whole problem with the recession started, we have to go back to the United States, where the Lehman Brothers bubble happened. And what was really the problem there is that suddenly, when a company with so many activities, a global company across the world, had had underestimated the risk of the finance related to mortgages. So when this happened, a big change occurred, which has to do with in economics, it's very easy to understand, but every company has a role to maximize the profit. But when this bubble had bursted, really what happened is that they had to deal with a big debt. And this happens in every part of the world, not just for a company. But someone had to pay the bill of $30 billion. And the government of the United States, they couldn't make the decision to bail out this company because there were 3 more companies to bail out. So I don't know if it was wrong or it was correct, but they made a decision not to support this. And if you see from this diagram, what would be the most optimal way of dealing with the recession is to have the slope on the right, the interrupted line. But actually what happened, because of the policy that was adopted on that occasion, the recession was really deep and affected as a domino effect the whole global economy. So as you can see, that you can be, one of the characteristics of capitalism is that you can be the most successful company in the world, but the risk and the way that you handle the risk can drive you to bankruptcy. So that's what exactly happened in the United States, and this created a domino effect. But most of the people, they say that this was a corporate governance failure. In reality, there is a document around 2,000 pages that you can read the causes and the effects of particular problems in the executive board of this particular company. But one characteristic was that all the directors in this company were more than 70 years old, and none of them had any relations with finance. So if we try to examine the current context of cardiac surgery, we can see that if we do an operational management analysis and we focus on cost, dependability, speed, quality, and flexibility, which has to do with range of services, I can say that cardiac surgery did the same fundamental mistakes. For many, many years, was really disconnected from the diagnostic process in our specialty and gave this to other stakeholders, with result now to be in a difficult position to recognize that the volume of cases has been reduced, that the innovation is slowing down, and although cardiac surgery is $1 billion industry, at the moment there are specific operational problems in every aspect of the operational process, but also in terms of the future of the specialty. So why I selected this topic? I believe that the way that we handle the uncertainty is a very important element of our scientific way of thinking, and also there are some specific characteristics that have occurred in the cardiothoracic specialty that can be explained by considering the way that we handle the uncertainty and the way that we handle the economical effects, especially with the development of a specific part of economics now is dealing with explaining the depression that has occurred, and this can affect individual, society, and organizations and business. Basically, it can affect every aspect of our world. And the way to explain what happened really is that you need to think about the ice cube experiment. Let's imagine that there is an ice cube and melting into a small puddle. If we start to look at it, we can describe the volume of the ice cube, and also we can describe in many different shapes that can explain the way that created the puddle. So what exactly shows is that it can create two types of thought. One is, has information been lost in this process? And the second is, should we trust the theories? Because most of the theories really cannot constrain in a particular, they cannot really constrain enough in order to explain all the available data. But we usually find the theories that they give some sort of predictive power in the existing data. So the important points that I would like to make is that the human has an inability to predict, has complete inability to comprehend uncertainty, and what this has resulted into what I say epistemic arrogance. Now, if we take other specialities from risk management, there is an expression, value at risk for businesses. Now, why this was invented? The reason that this was invented is because they wanted to create a false sense of security. This is like having an airbag that works usually all the time, except the time that the car has a real accident. So that's what happened with the financial situation. That's what has happened with the healthcare, and I will explain further down what I think about what needs to be done. So what are the most common mistakes that can happen during recession? The first thing that can happen is that there is loss of talent. The second is that the decision making is very, very difficult. There are cutting costs and compromising, which can compromise important areas in research, and planning is influenced. Also, research and academia are negatively affected, and education and training can deteriorate. What I'm interested more when, for the results of the recession are two groups of people. The first is the young people that are within the specialty and they try to find a way to be trained. And the second population that I'm interested in are the elderly people that for so many years through the tax system they paid the bill for the health care. So I'm very sensitive with these two groups of these two populations. So when we talk about loss of talent, there are several aspects that can be, this can be analyzed, what we say talent management. And there are 8 areas that are vital and important, like how to find the talents, how to assimilate the talents, how to deal with rewards and things like this. And every part of this is equally important. Now, the implications of talent loss are very, very significant, because if you have if you lose a potential a very important scientist, or this is important for the business relationships, this is important for the credibility of the organization, this is important for the culture, this is important for the customers of the healthcare, and this is even important for all the stakeholders. So what is the way out? The way out is integration, and when I say integration is all the 8 core principles of managing talents need to be addressed, each individual, but in an integrated fashion. So recruitment is important, maintenance is important, organizational culture is important, and at some point, all these issues should go to the top. So why decision-making is more difficult during recession? We can see this diagram which demonstrates that in the previous years, food and housing was more important and more expensive than other aspects of money spending. But nowadays, most of the curves, they demonstrate that medical care is a real issue for the future, because the population is aging and significant demographic changes drive this to a real driver for creating public debt. So the bad news between all this is a diagnosis. The diagnosis is a fragmented delivery system. And when I say it's a fragmented delivery system, is with a super subspecialization that has occurred. There are clinicians many clinicians are involved in patient care. Most of these clinicians, they know more and more about less and less until they know everything about nothing. There is less and less about more and more until they know nothing about everything. And clinicians are approaching patient with a discussion, is this what I do? And it's a real diagnosis that too many people, too much to do, and no one with all the responsibility or all the information available can make decisions. So if we think what the cutting costs approach has into the specialty, then it's very simple to understand that when we are cutting costs, sometimes you need to cut costs even from important areas, and this affects prioritization, this affects the all speciality, the way that functions. So we need to understand also what is the dominant factor of the costs. And although there are several factors that can be can attribute to the cost, the most dominant factor is the actual progress that has happened in the delivery of medicine. So there are other issues like safety and reliability issues, but the most important is the progress that has occurred. Now, is there any way out of this? And is there any optimism? Yes, there is optimism, and this comes from the if we think what is going to happen to the healthcare. At the moment we have a transparency trend, then in the next few years it will become sensitivity about performance at different levels. In the near future, what will happen is what we say clinical re-engineering, and this involves innovation, open innovation. This involves disruptive innovation. This involves strategies like blue ocean strategies, as they say. But what really has happened is that all this problem can be explained with prospect theory. What this graph shows is that people are more familiar with, are more comfortable to take a risk to lose less rather than taking the big risk to gain a lot. So basically, the humans are more sensitive to the loss rather than to gain a lot. So this explains why we should make decisions. The big problem with the financial recession that happened in Lehman Brothers, it was that they took risks that nobody really asked them to take this sort of risk, but they did it for their own benefit, to increase their salaries and to increase basically the income of the directors, and not for the maintaining the 5,000 jobs that were lost automatically in London. So they took the risk, but against the will of the people and the public. So if we discuss about this, we will see that the company had zero social responsibility. So what is happening in healthcare, we can see that cardiac surgery for many years hasn't even taken a role on the way that the specialty should be reimbursed. Of course, there are initiatives in the society discussing the different models of care, but really they haven't clarified the way that the specialist should be reimbursed, and also the models, the economical models, and the way that we should get paid for the job that we offer. Also, the impact of the specialty in the society has never been addressed in this country or internationally. So this is a big challenge for the way that the specialty has reacted to the financial constraints, and also the way that the specialty has decided how to run in the future. So there are two types of revolutions. The one is the industrial revolution, but what we need to focus on is that simultaneously there is a cultural revolution. And when we say there is a revolution, at the moment there is quite a lot about electronic medical records, quite a lot about information technology, and all these things are important and have been highlighted in the quality agenda, that are important parameters that require knowledge from social sciences rather than scientific knowledge and technical knowledge. So if we think about what are the drivers for complex systems like the healthcare system, we can classify them in three categories. One is what I say, evolution. The other is the development. And the most important is between the two of them, in the apex of the trigon, is what we say utility. And that's where the computation, where the predictable optimization and all the other concepts are involved. And these are important concepts, the way that we describe complex systems like the healthcare system. So most of the problems in cardiac surgery, most of the decisions are in the gray zone, and a lot of professionals, they should look around them and to see what are the other people do and how the current variation in practice can be explained. Because when we address this question on variation, then we can decide what is the way out. So if you see these two graphs, the one on the right has a lot of variation, and this, what basically says is that variation is reflecting basically that there is a problem there, and this problem is very difficult to resolve. When there is little variation, then possibly the solution is much easier. So the first thing when we have problems with variation is to divide if there is an existing standard or there is not an existing standard. For both of them, the strategies can be different, and the certain is that when you have a lot of variation, a bottom up strategy is very important, and because we need to involve the physicians to commit themselves to this progress. So with regards to the planning is always influenced when we have economic recession, and this planning can be strategic, can be marketing. In my specialty, the marketing is non-existent. For many, many years, we ran a global business of $1 billion, and there is no marketing plan for cardiothoracic surgery. Also, the planning should be operational. And all these levels are important because most of the plans during recession, they need to be redirected, and new decisions can change what the priorities are. So there are a lot of remaining issues. For example, the first remaining issue is that there is a fragmented delivery system. The second is that there is a chaos. There is a problem with reliability, with safety. Charles Vincent created an institute that is dealing with safety. So a lot of adverse events are happening in the healthcare, and this is a priority. Safety is the priority in cardiothoracic, in cardiothoracic surgery. Also, there is a great opportunity for leadership. And when we say leadership, I will explain later that this can be defined in the specific area of the high-risk situation that we are at the moment. Also, research and academia are negatively affected. And if we try to classify what needs to be done in terms of choices for technological development, this can be classified in nanotech, biotech, information technology, also brain sciences, and applications from sociology or social networks. So this is very, very important because the first and the second mover will take the advantage to manipulate these particular areas of science. So another area that is also important is the education and training, which affects the young people and also affects the future of the specialty. Now, a lot of things have been discussed about the value of research, the value of the RCTs, but if we think honestly in our specialty, and we think from where the progress has come, I would never think that the randomized controlled trials transform the cardiothoracic surgery. In my mind, are important for the decision making, but is not the main characteristic of cardiothoracic surgery. The main characteristic of cardiothoracic surgery is the original intelligence of the cardiothoracic surgeon who is next to the patient and deals with innovation and technology. This is, I believe, in my mind, the most important parameter. So what is missing in cardiac surgery? There is a problem with the vision. There is a problem not nationally, there is a problem internationally. There is a problem with how to recruit and retain the most clever people. There is a problem with credibility, and there is a problem with values and the disconnection from the patients. The specialty needs to go back to the pathways that bring the cardiothoracic surgeon back to connection with the patients. So if we want a way out for this, then we can think that the way out for this is that we need to put teams in strong and committed teams together, involving surgeons, engineers, bioengineers, biomolecular scientists, industry, and focus on systems that address important needs. Also, we need to have measurable targets, and the most important, to enjoy ourselves. And I thought, what is the best leadership when you have a permanent crisis? And there is a review that has been written from a Harvard Business Review focusing on permanent crisis. And when the economy recovers, things will not be back to normal, and different needs are required. And the most important that is required is we need adaptive leadership. And adaptive leadership is to maintain what is important for the specialty, but also to enable new practices that can adapt to the new world. And the new world has specific characteristics. And I will go through these characteristics later on. But the most important is adaptation. The second important is to create to the people that are involved a discomfort that to that change needs to be implemented, but also not so much that they fight around it or flee or freeze around it. So nobody really wants to change. Everybody wants to stay as he is or as she is, but the most important is to embrace this equilibrium. The third parameter is that you need to create systems that generate further leadership. And when we say deep leadership, we mean from the top of the organization to the bottom. And during these changes, there are people that, because they keep authority positions, they try to tighten the control, to take across-the-board cuts and restructured plans. This is the way that they react. Of course, this is something that can save not really the organization, but can save their positions. The future requires different sort of leadership management. So if you want to make a picture of what is happening, is that we need to keep a hand on the thermostat. And what this means is that if the heat is too low, people won't make difficult decisions. But if the heat is too high, then they will start panicking. So what really is important in leadership is that, as I said, to generate leadership deeply within the organization, but also to transform this climate within the executive team. And people that are really come up with the best solutions, they can take a place in the real executive and strategic team. So I would like now to present some of the work that I consider as translational and has to do with the people that I'm currently working. And this is not really my work, but I have to present some of the work that is important. And I consider that when you want to change something, then you need to use the levers that are available to you. And the levers that are available to me, I have considered that are two of them. One is the information technology, data analysis, analytical work, modeling of different systems that they work in the healthcare, different business models for healthcare delivery, and from the other side, nanotechnology. So if we want to think in a different way, we need to understand the context that cardiothoracic surgery lies in. And this context has nothing to do with the current scientific context of our specialty. We need to think much, much broader than this. We need to think what are the other companies, what are the other tools are around us, because this is the really important neocortex for the brain of cardiothoracic surgeon rather than the usual knowledge of the textbook. So I would like now to emphasize some cardiovascular research themes. Between some of them are the clinical excellence and innovation, the development of biomarkers, evidence synthesis and comparative effectiveness research, cell therapy and metabolic surgery, surgical technology, and academic performance and impact. These are the areas that my thoughts are focusing at the moment. So this slide shows that there are important concepts in cardiothoracic surgery, like the biological concept. For many years, we were doing Ross operations, we were doing homograft work, and we need to think how we can enhance these treatments and how we can create, how we can integrate these concepts with new concepts that we can increase the effectiveness of biological treatments. This is something that we described in this paper, and this lies within one of the areas that I consider important for me. So some of the important areas that we are working, and this is a work that is multidisciplinary between the Department of Biomolecular Medicine with surgeons involved, with Professor Nicholson, Elaine Holmes. All of them, they have created the environment to deliver high impact molecular research, and we follow, as surgeons, we need to follow towards the same vision, that we try to address questions that are important in translation, like the cardiovascular effects of bariatric surgery. And this is very important strategic area because it has to do with the resolution of the diabetes, has to do with the current observations that there are systemic metabolic effects of bariatric surgery, and these effects are very significant for the treatment of metabolic syndrome with significant consequences and significant economic consequences. And also, as Prof. Nicholson had said in the past, that possibly there are so many, the microbiome within the human body, the gut, for example, can be so important for every type of disease, not only in cardiovascular, but has to do with cancer, has to do with neurodegeneration. So it's a very hot area that I consider that is important as surgeons to invest in this area and look into to elucidate some of the concepts, like, for example, are we in charge of our body or the microbiome is in charge of our body? I cannot give the answer at the moment, but I find it very exciting area to focus on. So another area that we are focusing is to identify if there is a relationship between cardiac failure, obesity, and bariatric surgery, and how bariatric surgery can facilitate or can help the human body to adapt to the new conditions, basically to describe the enterocardiac axis. And these systematic effects can go to every type of basic science, towards endothelium, towards adipocytes. And I just don't want to expand more on these areas because there are other people more that are more familiar with the novel concepts in these particular basic science research areas. What I would like to say, though, is that from a randomized controlled trial that has been done at Charing Cross, and bariatric surgery has demonstrated on functional studies in the heart that can address problems like ventricular remodeling. And this is a very important translational observation. So another concept, for example, is to combine the concepts of the Department of Biomolecular Medicine to increase the synergistic effects of coronary artery bypass grafting and gastric bypass in the obese population. And this can be, what I say, novel concept, because integrated strategies and especially enhanced strategies can increase the efficacy of the current existing treatments. And this is very important for science and translation. So other aspects as well is to study the cardiorenal axis after bariatric surgery. And I would like to move to another area which has to do with biomarkers for very common diseases in cardiac surgery, like atrial fibrillation. And this is really very important work that has, again, aimed to identify biomarkers that characterize the most common complication after cardiac surgery, which is postoperative atrial fibrillation. And this work has driven to a recent development of a biomarker which has to do with particular microRNA targets. And this is the microRNA 483-5P with the specific target that has been identified, which is the VCAM1. And this is work that Liane Harling is leading. So I think that from a translational point of view, this is a very important piece of work which has been funded recently significantly from the Wellcome Trust. So the next work is about systematic inflammatory response, and this is work that one of my PhD students is completing at the moment, and this is the role of toll-like receptors in systemic inflammatory response. Basically, the toll-like receptors can be the sensors of the inflammatory response, and the way that we have thought about it is to create relevant animal models, one mouse model and one porcine model, and this has to do with the hypothesis that mitochondrial DNA can be altered during the inflammatory response of cardiopulmonary bypass, and this work has demonstrated with significant results of mitochondrial DNA, which we can see here that is increased in the on bypass group, that there is a reduction in new techniques of cardiac surgery like the off-pump group, and also that we have an animal model that can be potentially reproduced with giving anti-inflammatory agents like sulforafan. So these are important areas of research in cardiothoracic surgery. The other area that is important is that we tried to assess a very common parameter in aortic stenosis, which is aortic stiffness, and we tried to correlate this with biomarkers like the BNP, the NGAL, and the NR2AB, and basically to try to connect the aortic stenosis disease with other organs like the brain or the kidneys or the heart. So this has demonstrated significant results that actually we have identified physiological mechanisms that can be related to quality of life and to cognitive function. These are preliminary results, but I personally think that is a quite neat piece of work because he will give us new opportunities to explain cognitive dysfunction in the elderly population undergoing cardiac surgery. Another area of technology that we are focusing is that there are quite significant new conduits that we are using at the moment for vascular reconstructions in cardiac surgery, but there is no model for assessment. And especially we haven't identified how we can compare this to the normal population. So we have adopted this strategy to assess flow with the Department of Fluid and Dynamics, basically to assess where the stress occurs and how this is related to particular technology or how is related to disease process. Another area of research that I'm interested in is how we can assess academic performance and how this relates to leadership and mentorship and how this can be translated to increase impact. The basic idea of this concept is that I think that in order to analyze the impact of science, we need to go back to social networks analysis and to go back to social theories. So the way that we have gone around is that we assess this with social networks, and you can see the different patterns and the different characteristics of different level of professors, lecturers, and readers, and how the characteristics of the network can be significant for the future of science and its impact. So also we have identified that the H index that has been used as a tool for assessment is not an homogeneous metric, but can be further explored and further analyzed. And in the past, I focused quite significantly on how we make decisions and how we can improve these decisions. And I used meta-analysis, decision analysis, and economical analysis, and this has been highlighted by the media as a way of addressing the most common operation and the most common intervention in cardiac surgery, which is the Lima to LAD graft, which has changed our specialty. Also, recently I published the first Bayesian meta-analysis in cardiothoracic surgery, assessing what is the best way of revascularizing the right coronary system, and we didn't identify that the arterial grafts are superior to the vein grafts. And this is something that the current literature had never been concluded and is associated with significant uncertainty. We use cutting-edge techniques for different questions of interest within our specialty. Other times we focus on cost, other times we focus on decisions, other times we focus on putting outcomes to be assessed in terms of uncertainty, in terms of heterogeneity. And this is the way to clarify what the new hypothesis on the best treatment should be. Is a technique that we reduce the data available and we extract the information in order to assess future questions. Of course, we accept that this particular technique can be used only to inform healthcare policy because our specialty has quite a lot of impact on quality of life and has to do with other aspects of decision making by the government. We have used a similar methodology for diagnostic tests, and we have used, for example, hierarchical summary ROC curves in order to identify the role of diagnostic technologies and how they can change the current decision making in cardiovascular disease. We have come up recently with heat maps, which is a new tool for network meta-analysis. This gives a new opportunity to describe efficacy matrices on the way that we analyze different complications. Basically, we have a reference treatment, and against this treatment, we can compare all the relevant treatments, and we can come up with decision tools that can help health policy makers to make their own decision. The synthesis of research for me is quite important because from this, you can identify areas that you can really design strategies how these particular findings can also be implemented, not just identify what exactly the benefits and harms of treatments are, but also ways that you can change the implementation of these new findings. In my mind, randomized controlled trials can be considered important only within the framework of in comparative effectiveness research, and basically we need to focus also on diverse patient populations and subgroups, because that's what really is the problem with randomized controlled trials. The group that they have been, that the randomized controlled trials have been done is so highly selected that at the end we are not able to generalize our results, and this makes what I say the randomized trials quite redundant. Other work has been done with, in collaboration with Sam Harding and Molly Stevens, and this is another PhD student that completed almost his thesis, and this was on a particular area of iPS stem cells. For me, I'm not the most expert. This work was done by Dr. Terracciano, and was supported and had significant findings, the way that iPS cells should be used or developed, or better, in a better way, the way that can be used in an efficient way in cardiovascular sciences, has to do with defining a platform that these cells can develop and function better. So this work was recently published in the BIOMATERIALS, and the finding was that new types of substrates can help to and facilitate the way that the stem cells handle the calcium. And this is important, and work that has been produced by a multidisciplinary team involving basic scientists and surgeons. Another piece of work has to do with the idea that can we really find a smart way of giving biomaterials onto the heart after a heart attack. And this work was done with the aims to develop to apply the material, to characterize what factors we can give with the material that we inject, and also the clinical results. At the moment, this has not been applied in humans, but in a preliminary study that was done with functional MRI in a mouse model, has demonstrated some encouraging results. So this work as well should be taken further to address the issue if we can deliver erythropoietin, for example, which is a very common doping drug that has been used recently to create world records, especially for people that are interested in cycling. You can see that all the performance there is due to erythropoietin rather than personal skills. So I will go now through some clinical excellent results, and I would like to present some work that has to do with the surgeon, that because most of our practice is to design new concepts, and I think that some novel cardiovascular concepts is to design hybrid treatments, to come up with disruptive innovation treatments, and also to create enhanced functions through integrated treatments. So this is a very complex problem that I came across. This is a patient that had an aortic dissection and had a arch involvement, had also a fem-fem bypass, and this patient, it was quite complex, and the only way to address complex problems is to find neat solutions with new technology, and this is a frozen elephant trunk device that was delivered through the open aorta, and was followed by a total arch replacement with individual implantation. This is the first case was performed in Greece by myself, and the final result was that this patient had 6 operations, and the case report was published as a case report because nobody really believed that would survive 6 operations with a history of tracheostomy before and so extensive disease. But in a young population that can take high-risk operations, this can be a good solution. This is the work that I really has helped Mr. Kasula to develop the last few years. Minimal access is a way forward in cardiothoracic surgery, has demonstrated that is a different concept, it requires different training, and requires different resources and different marketing strategies. So in my view, this is the new area that can be developed, because there are new devices, like for example, to be able to change only the internal part of the valve, which now has been, is within the business plan of companies that are very important in this area of delivery of these new devices. But in the future, these particular concepts that come from the leg or from the apex of the heart will be finally reduced in few valid options. And this is going to be the future of this technology. Not really the question who is doing it, but in what population, how these concepts can be integrated in existing valid concepts of cardiothoracic surgery. In the past, we had developed as well other operations like redo minimally axillary LAD bypass, when especially the LAD, the internal thoracic artery is not available. And this concept actually is a very important one, because can reduce a complex operation to a 1-hour operation. This patient was admitted with an acute MI and was discharged home on the 3rd day. And this operation also can be used as a conversion for robotic operations, when the robotic operation fails, as an exit for a complex strategy for management of complex cardiac disease. I don't want to go through this. I would like only to say that in the past we were used to do the mitral valve through the sternotomy. The recent results, the recent experience, and surgeons, like as I mentioned, my colleague Mr. Kasula is pioneering this technique and has significantly improved the current practice and gives opportunities to new ways of managing this disease. You can see here a case that was undertaken robotically at St. Mary's a few years ago. This patient left the hospital on the 5th day without any complications, and this was one of the first cases that was undertaken in UK. was the first robotic closure that was undertaken at St. Mary's Hospital a few years ago without any front incision. And we had described that all these concepts of changing the way that we address cardiac disease can change the timing that we intervene and also the population that we intervene. So give us a lot of flexibility, and this has to do with the operations management of our specialty. Basically, we can offer speed, flexibility, and these operations have an important role to expand the range of procedures that we undertake. This is the way that the revascularization has progressed through the cardiac surgery. We started with off-pump techniques, we moved to ROBOCAB, and recently we have performed more than 130 robotically cases without any opening of the chest. So this demonstrates leadership, this demonstrates an academic program that has a value, and at St. Mary's we had produced our own algorithm to revascularize single vessel disease. And during the last 10 years that I have been at Imperial, I remember that we have undertaken more than 600 minimally invasive revascularization operations. So if we want to conclude, we can say that there are three options for revascularization: the minimally invasive, the conventional, and the robotic, and in the middle is the patient choice. Now, this was the first patient that had undertaken a robotic bypass without any incision in his body, and you can see the shape. You can see that this patient left the hospital on the 4th day. So this sort of innovation is an important aspect of academic and clinical cardiac surgery. It's important because you can develop a program, you can accomplish your vision, you can offer improved patient care, you can increase your volume of cases, you can facilitate access to different sort of cases, and you can give also research opportunity. Of course, focus is what is required between addressing the issues of cost, patient selection, and healthcare provider. In our department, there is a valid platform that gives opportunity with the Guangzhou Yang's work to be integrated to a different world that can increase the capabilities of surgical awareness. So these platforms can be used, and in association with a clinical program can really transform the way that we think around cardiac surgery. So, as I said, the total, what is going to change is that the total information that we get from these systems that has to do with patient-specific models, surgeon movements, all together in association with performance task modeling, all of them, they create a new digital platform. And this digital platform is the one that can be analyzed and can be reproduced in a way that we come up with design of new instruments and new operations for cardiac surgery. Another important driver for adoption is that this will increase the opportunity for mentoring, will increase also the opportunity that we can use simulation techniques with robotics. So if we want to create an academic program in cardiac surgery, what this program requires? As you can see, requires patient care, research, education, focus, and the most important, requires leaders. And if we want to create an institutional vision, I would go with the second one, which is a more practical one, that we would like to create an institution that trains our students and be prepared to improve healthcare system and adapt rapidly to change. The operating theater, everybody knows that is not as it was before, has CT, has MRI, and basically is an information system. And this needs to be associated with professionalism and skill. And the skills, our department has has a lot of work been undertaken in our department, and this will help a cardiac surgery program to be integrated with existing work, because the department has really strengths in assessment of skills, the work of George Hanna, the work of Prof. Darzi, all this work can be is transferable to cardiac surgery. So if we want to go from novices to surgeons and mastery, is this enough? In my mind, it's not enough. We need to develop some more skills, which is to develop intelligence. And in order to develop intelligence, you need also to address ethical issues. And on this particular area, the existing knowledge of doctors around what is a moral question, what is a new development, is this good for prevention of disease, or is the technology will make the humans better humans? These are the questions that I think are quite important for the transformation of my specialty. So if we think about the skills that are required to innovate, there are two types of skills. One is the technological transfer, which is the first chasm, which is the valley of death, as we say, and the second, which is the sustainability. So an innovator must have to be able to see the big picture, to understand the science, to be able to use what we say, to be aware of the transition of the technology. And they need to cross this chasm twice, not once. So in a paper that we did that attracted quite a lot of media attention, we demonstrated that in the last few years we have seen that very few clinicians have awarded the Nobel Prize. I think that this is very unfair because there are interventions like the hip replacement that really change this world, creating significant social impact. Now, what is the future of medicine? The future of medicine, in my mind, is predictive, of course, involves system biology, is preventive, has to do with the point of care, has to do with defining standards, compare this to baseline, and also has to do with personalized medicine. So if we want to see the challenges of the new century in healthcare, we have to answer the following questions. Do the new technologies represent added value? Do they, the new technologies offer minimal or new dimensions over the existing choices? Do they fail to reach their potential? And the last one is that, do they work for all the patients or some of them? Now, I personally believe that the comparative effectiveness research is a very significant synergy with personalized medicine. And why this is because you can put under a particular model genetic data, behavioral data, environmental data, and all the other types of data with regards screening, diagnostic, therapeutic, and interventions, and create one model. And this model gives a specific opportunity to analyze the effects on subgroup of patients and subpopulations. So if you ask me what is the future of cardiac surgery, I think the curriculum needs to be reorganized with biodesign mission, and I think that should be added in the curriculum of the new cardiothoracic surgeons, training in innovation and biodesign. And this program should have research, should have education, technology transfer, and ethics and policy. And if we talk about disruptive innovation, one way to describe the effect of disruptive innovation is that disruptive innovation decentralizes the healthcare system, moves the innovation from the hospital home. And this is a very important point to differentiate what we say sustainable innovation and disruptive innovation, because the decentralization makes the disruptive innovation a tool to transform healthcare. So if we want to apply a model how to create the environment for disruptive innovation, there is this model, the LIPS model. It's something that I really like because The first thing is to know about yourself. And the last thing is to enjoy the journey, because it's a big journey from the way that you think an idea to the day that you will see this idea implemented. So I like as well new concepts in cardiac surgery that like the one that is what we say dematerialization. And what this offers is that using ways of thinking from using less to produce more. These concepts is a new way of thinking that can transform cardiothoracics, the cardiothoracic as a specialty. So if we think about how the technology can transform the different sectors, you can see that the healthcare is the last one that wants really to change with the existing technology. Is one of the hardest areas to transform. And the important consideration is that the technology will offer the opportunity to move the healthcare from the acute to a preventive state. Now, in my mind, the future of cardiothoracic surgery should involve three areas: the prediction, the management, and the creation. These three areas will assist the cardiothoracic surgeon of the future to develop its own intelligence. And I would like to mention the people that influenced me more in my way of thinking. I would like to mention Melina Mercouri, Cornelius Castoriadis, Professor Trichopoulos in the Harvard Professor of Epidemiology, Mr. Ross, and Prof. Darzi. I would like to thank all these people for the interaction that I had with them during the last few years that I am trying to do translational research. Of course, these are the people that helped me to put this presentation in place, and I will never forget all the other people of biomolecular medicine, bioengineering, that have contributed significantly in this type of work. I would like also to mention that what I learned about life is that you can easily win by yourself a game, but it's very difficult to win a championship. And in order to win a championship, you need to learn how people win. And this is the title of the new book that I'm currently writing. And the key point of any winning strategy is the cohesion. Without cohesion, without a network, with 100 people that I have written papers together, nothing would have taken place. These are the two books that have been produced from our department with the help of more than 50 individuals. And something that I would like to mention is that one important aspect of life is that the model culture spends quite a lot about talking about the past and talking about the present, but has very few to say about the global future, about the future that affects all of us. And in my mind, this is a very important consideration. Most of the people, they just talk about the past and about the present. And what is happening around us is very characteristic. There is, as I said in 3 words, there is a finite sphericity, there is acceleration, and this is the change that is happening, and we can see this transition phase that is the evolution of the human. So it's very important to go back to the ancient Greek when we classified the world in very few words, and this is what it is, what we want, and what I want. And this is basically the bonus model that came recently, the ways of thinking. And basically has to do with conceptual models that nothing is really new. Everything was there. Whatever you want to write nowadays, if you look carefully, somewhere else has been written. So what is, in my mind, the universal direction? The universal direction is something that I read in this particular book by Fuller that says that in the future, it will be matter, energy, space, time, and this will create compression, efficiency, and density. And in my mind, this is a very simple model to understand what black hole is in the universe. Thank you very much for your attention. I will be happy to take any questions.